Welcome to the Movement Podcast. This show is all about movement, giving you a better idea of how you can optimize the human body to be the best it can be.
Great, we're really excited today. We've got Dr. Cortney Herndon with us, and I'm going to let her give the background, but I'll give you the background so everybody kind of puts it in perspective. Cortney started working with us when she was in PT school as a student.
Yes.
And so we've got a long history with Cortney, and really excited to kind of get into a lot of what she's been doing since kind of, going through the FMS experience almost 25 years ago. So Cortney, thanks for joining us today. I really appreciate it. Could you just take a couple minutes and kind of give us your background, kind of what you're doing now and kind of what your experience was early on in your career?
Yeah, sure. Thanks for having me. I'm excited to be here. So my background is in orthopedics. I started out, I was at the Medical College of Virginia, and I just reminded both of you that you guys came through with the FMS kits and screened my class when I was there. So that was really the first time that I briefly met you both, and then had Gray as a clinical instructor when I was in school, and that was really invaluable to the trajectory of the way I treat patients, because he really taught me to look big picture. He was my CI, and then I also had another CI, and she was very structured and what you would expect from a CI, and then Gray was outside the box all the time. And so I had such a great balance of that with the two of them. And so I learned from the ground up, just look at the big picture and then kind of hone in on what's important, not just the joint itself, but the picture of movement. And so I really carried that forward, got out of school, got a job with Gray in the clinic, and for about 4 years, continued to learn. And I can still almost see him in my head doing an evaluation. I watched him a bunch. And I was like a human sponge. I just wanted to know anything, and learned a lot from the people that worked with Gray for a long time. If he was doing it, we were all drinking the Kool-Aid. We were all doing it. So, and it really, the patients benefited from that tremendously. I do remember at that time you guys were working on not just FMS, but SFMA. And so I really saw it from the ground up, what was happening, and thought it was really neat to just even be part of it and get to see it be transformed. And there have been a lot of changes to that system over the years, but that algorithm for SFMA is really how I've seen you go through evaluations, maybe not step by step, but very similar to that.
No, it's really weird. This morning, first cup of coffee I was getting down, I realized you two were the only two people that actually came to our clinic fresh out of school. Mm-hmm. So even though you had your background and your discipline, you didn't really have to unlearn any inefficient treating habits. You just sort of hit the ground running and ran with it, where almost every other PT, PTA, ATC that came through the clinic really did come to that crossroads in their career where I got to do this new thing and feel a little bit vulnerable for about 5 minutes, or I just got to go right back to fake and bake and tape.
Yeah. Well, I realized when I went back to school after my internship, I do things differently. I'm thinking differently than some of my classmates who had very different internships. And so it still didn't give me, I still had that imposter syndrome when I got out of school. And I remember you took me to a course with you to assist, and I said, I have no business assisting you. These people do not want to hear from me. And you said, no, you're doing things differently. Remember that, you think differently. And we went to the course, and I did see that. I definitely did not feel smarter than anybody in that room by any means, but I just realized, okay, I really do think of movement differently because of how I was trained. And that's really carried me forward in my career, because I had those systems in the background, and then I wanted to learn more about assessment and dive deeper into that. And so then I started taking manual therapy courses through Maitland. And really all of these things are just resets, but And the reset, I explain it to patients like you're turning your computer off and you turn it back on, and then suddenly the glitches are gone. And, you hear IT, I'll call IT and say, my computer's acting funny, turn it off. And I get so annoyed with that, but that's really,
Yes.
that's all the reset is, just plain and simple. You're resetting the system, you're turning off the glitch, and you turn it back on. And then I tell patients, look, we've got this window of opportunity. We can change how you're moving. And it's really important to take advantage of that, to work on the things that I give you. But Maitland's assessment and treatment is very similar to SFMA because you start big picture. And then you start just getting more and more narrow to where the active movement. So I bend over, I touch my toes, I have pain. So then the end of my exam, I'm at the joint, mobilizing the joint, and I'm saying, is this your pain? Yep, that's the pain I get when I bend over. And then I'm mobilizing that joint, I stand up, I reassess them. And so it just goes well. And then I can talk to them about, is this real stiffness? Or does your body just not feel safe moving in that range?
That's right.
And that's more of a, you can't control your movement. So your body says, hey, you can't go there. But it's available to you. We've just got to retrain that. And so people do, there's more buy-in when you treat people that way. And I think with SFMA and also with Maitland's approach, you can get that immediate buy-in because people want to see, how are you going to help me? I'm spending my time and my money on your table. How can you help me? And I don't want to waste their time or their money. And so I want to make sure that I'm trained to sufficiently treat their issue.
One of the things I want trainers and coaches who are listening to this podcast to understand is when we act as therapists, co-treating, and somebody else is working with a performance coach or a personal trainer or whatever, we come from a clinic where we had Keith Fields with a master's degree in exercise science running our gym. So I don't think that I could probably coach you through a chop and lift any better than he could. But I honestly want the coaches and trainers to realize sometimes you need a reset to the system. You do need a therapist, a chiropractor, a trainer with what we call manual therapy skills. Maitland, McKenzie, all these things are just ways to reset the body. You can do it with dry needles, you can do it with manipulation. But what we find is people who are too much in a manual therapy silo are fine just to keep resetting you. And I think what a movement approach allows you to do is we transition into that reinforcement. If I get you moving and you were to do this for a few days and you were to do this for your warm up and you were to do this in your workout, it would maintain. So there are actually, if you're working with a client that has an issue, there are far less PT visits if you find somebody who's not just going to do exercise like you do.
Right.
You need somebody who's going to do something different than you do and open up this opportunity to install a functional approach. But once we're exercising, if you're a good trainer or coach and you understand corrective exercise and what you're looking for, I would rather do what I do and allow you to do what you do. And so if you're not working with a therapist that's thinking like Cortney or talking in a functional reset way, then they are going to often just dispense some of the same exercises you're already doing at a more expensive rate.
Well, we've been preaching that for 25 years, trying to bridge the gap and get the professionals, the different disciplines talking. The fitness, personal training, strength conditioning, speaking more to the sports medicine, physical therapy, chiropractic world. And right now, it's still a battle because I think people are fearful on both sides of the aisle. If we go into the medical side, they're getting ready to discharge their patient knowing that the patient's ready to get discharged, but they may not be ready to go back to their sport, may not be ready to go into a gym and do the exercises that they want to do. Who are they handing them off to? Do you have a lot of confidence that you're going to hand them off to a person who understands that there's still some limitations that we got to work around, and vice versa? If I'm a strength conditioning professional, do I have the confidence that I'm going to hand this person who I know is broken, but not broken to the degree that they need, 6 months of therapy. They need some resetting. They need some tweaks, that they're not going to hand them off to a person who's going to just get them in therapy and keep them for, 2 months. So I think there's a lot of distrust in the professions that we've got to get past. And I think, even as long as we've been doing this, it's a battle and it's tough, because here's the one thing we know just with our research and our data. If the person is broken, they need medical intervention. If they've got pain,
they can't do it with exercise.
Yeah,
the reset has to occur.
Right. They've got pain and you can't just work through that. And I was reading, doing my quote unquote drive-by of the day on social media. And now the pendulum has swung up probably too far in the world of corrective exercise.
Mm-hmm.
Well, we got to do correctives. We got to do this assessment. And, basically, and Gray and I, we took a lot of heat for this early on, is that we were teaching fitness professionals how to assess. That was one of the things that we got hit hard for. And then all they're doing is correctives. Well, now the pendulum's swinging back, where a lot of professionals, a lot of people who are quote unquote influencers are saying, don't worry about assessment, just work them out. They can just exercise them. So, there's some things in there that we gotta work through. But Cortney, taking it back to what we're talking about here, you don't want to treat somebody for a month. You want to give them that quick little, intervention so they can get back to working out.
Right. I have a bit of a side hustle just because I want to treat the way I want to treat and not have restriction from insurance. And that's a whole nother discussion, but they really reimburse me less every year for the service I provide. And my training doesn't get cheaper, and the courses I take to be better at what I do are going up in price so that I can provide better care. And then insurance says you're not worth this amount of money. And so I want to have time with my patients to really treat them quality over quantity. So I'm treating in a gym right now in the evenings just so I can do PT the way I love to do PT. And I'm in there in the evenings when there's a lot of trainers and things working with patients. And it is very busy right now. So this is a hot time of year. People set those New Year's resolutions. They go out and they are all in. But I look around at really bad squat mechanics. I'll hear patients say, "This is killing my shoulder." And the trainer may say, "Just push through it." And I know that person is making an effort to be more active, more healthy. I want to see them continue that. And I'm thinking if they had gone through the functional movement screen, they may would have, pinned a shoulder mobility issue. And then they could have seen me for maybe 2 visits and then been back out on the floor ready to go. But the screen, and I've talked to some of the trainers there, because the screen will really tell them what they can do safely, what they should not be doing at all, and what they need to proceed with caution on. And it just, to me, makes perfect sense for trainers to do this. Anybody that comes into a gym should be screened first, but I'm definitely in agreement with you. It should not all be about correctives. If they have pain or some sort of limitation, a few sessions with a quality PT can get them back in the gym, and they're not gonna miss out. They're going to stay active, and then the gym keeps the membership, the trainer keeps the client, and everybody wins, but you're right. There is a lot of, I think, threat in that regard.
Because the one thing in the world of everybody's world, you kind of alluded to it with your side hustle, is the biggest way to make money in the gym fitness world is to keep your people in the gym. Yep. And that's retention. And one of the biggest reasons people stop coming to the gym is they get hurt.
Yes.
And then they end up in the medical model, which we know is broken.
Yes.
So that's one thing that I think, that's where the disciplines can work together, is give them a tweak, give the feedback to your patient at this point, but also the fitness professional. Here's some things that maybe you should avoid.
Right.
And that's the biggest thing when we screen someone with the FMS, is we're trying to give you things that, hey, this person should avoid. And you mentioned the word safely. These are things this person should not be doing right now, today. Tweak them, and maybe a week, 2 weeks they can't.
Right.
All right, let's take a quick break here to tell you about Simeo. Simeo is our holistic wellness platform designed to give you the tools and resources to assess, manage, and improve your clients' and patients' overall health and wellness. Go to Simeo.com to sign up for a free trial today. That's SYMMIO.com.
We got 2 new courses I think you'll like. One's a deep dive on mobility and one's a deep dive on stability. We really unpack that and show you how simple single corrective exercises aren't nearly as good as a meal of mobility assembled in a flow, in a set of stations. Do the same thing for stability. It's sort of a new way of looking at things, but it's that same old functional approach, just with nice packages that actually give you huge dividends. Our last summer tour with Perform Better, Lee and I, real time on a self-screen app, screened the audience. Well over 100 people on almost every venue, and it was therapists, athletic trainers, personal trainers, strength coaches, fitness enthusiasts. The room was full of people who have dedicated their mission to movement and exercise, and they were no more moving better or worse than the general public that they treat. And I think you said something early this morning when we were just talking before we came up here, that you love it when a trainer or a coach comes to you with an issue and you can show them how quick the turnaround is if you seek to uncover the blind spots. And even though our movement screening and assessment evolves with the population and with the data that comes back, at all times the screening process is to simply demonstrate and show you something you would have otherwise skipped in your intake. And so in physical therapy, what we call that is regional interdependence. I know you're coming for low back pain, but I am going to look at your balance, your flexibility, your posture, and your other joints, because that's what can cause your back to compensate. If you're not here for pain, but you do have poor movement patterns, that's great, because correctives don't look like medical exercise anymore. Correctives look like, let's clean up your toe touch, let's hit that deadlift. It looks like a workout if there's not pain on board. So the only time we really got to put on brakes is if one of your movement patterns is painful, and that's simply the body giving us a signal of disharmony. And you can't cover it up but so long, or you're going to wind up with a longer term problem. But we keep adjusting and tweaking screening and assessment, not because we can't make up our mind. Believe it or not, the population's changing. And we used to have about a 20% fail rate on a pre-participation athletic physical. It's closer to 30% now. Same thing with wellness clients. So there's a lot of people being told to live with pain, work around pain, take the ibuprofen before you play tennis, slap some magnets in your shoes, whatever the flavor of the day is, to make pain the subject of the conversation instead of a signal of disharmony, which is all that pain is. So.
Well, one objective, Cortney, and I'm going to kind of let you take this topic and go with it, and we'll just figure out what direction it goes, is one of the objectives when Gray and I were talking about bringing on guests is like, we need someone who can speak to female athletes, and not just athletes, but females who are looking to train, and some of the problems, some of the things that we specific to females have to overcome, and really in the strength conditioning world or physical therapy world, consider as they're going into this. So speak to some of the things in your background that we need to be considering that Gray and I can't necessarily speak to in this world.
So I'm not a trained pelvic health PT. I do want to preface my comments with that. I've had some pelvic health courses with Herman and Wallace. They're a great group. I work alongside a pelvic health PT, and the one thing that I've noticed is that sometimes with female athletes that are having pelvic health issues, less is more. That particular population, education is very important. I tend to be, I don't want to say aggressive, but I'm very functional. And if I follow the 4x4 matrix with if you start them in a certain position, you end up in a loaded position, and kind of progress them along that way. But I do so fairly quickly. And with pelvic health clients, I find that less is more, in that it goes back to breathing a lot, breath with movement. I see a lot of runners by default. My kids are runners, and so I get a lot of even high school athletes that have incontinence. They go from cross season and everything's
what is
fine.
incontinence?
So
Give us that
it's
one.
when they leak urine.
Okay.
And you can have urinary or fecal incontinence. And pelvic health therapists treat both. I do not do internal exams. I've done external. I can needle the pelvic floor, which I do find to be very beneficial for that reset. I've heard the pelvic floor described as a room with four corners, and I love that analogy because a lot of stuff is attaching on those four corners.
Yes.
And so, if you think of a floor and if one corner settles, what does that do to the rest of the foundation? And so, I think that's a very basic way of thinking about it. So if there's a hamstring problem or an adductor problem, hip mobility comes into play a lot with pelvic health patients. And in particular, female athletes, I think they feel like it's normal. Like, oh, I went from cross season, a lot of distance, and it's more distance training. And then they go into track season and they're sprinting. And it's like, why when I sprint am I urinating on myself? I don't understand what's happening.
So Cortney, speak to this. When as a coach, whether I'm just a coach or a fitness professional or a parent or an athlete, what are some of the indicators that I should say, okay, I need to get this checked. I need to go to a medical professional versus, man, I can just train through it. What would be some of those things that someone should consider?
I mean, obviously pain, but I find teenagers don't typically talk about this. So maybe adults would be more willing to discuss this with their doctor or whatever. But, I actually heard a group of teenage girls talking and laughing about it, like, oh, it just happened. And I just immediately said, that should not be happening. You should go see a pelvic health physical therapist. And now we have direct access in Virginia, at least. And so, they can go directly to a pelvic health PT and discuss that and find out they probably do need an internal exam. They probably, they're going to get a movement assessment. A lot of times it comes down to our therapist says, do they need up training or down training? Meaning everybody thinks, well, if I do Kegels, that'll stop. And Kegels is just tightening the pelvic floor. However, not everybody needs that. Some people need down training, meaning they need to relax their pelvic floor. And so the exercises are quite different for that. And so you would need some sort of internal exam usually to specify that. They can get trigger points in their pelvic floor, just like they get trigger points in any other muscle. There are ways to address those with wands and, internal work that they do even outside of therapy. I know that the adductors are typically pretty tight on those patients and problematic. And with that, there's some, like I said, some hip mobility issues. And
all right, so let me dive into that a little bit, Cortney. So going back, so what I heard, and I think what most people hear, is the main indicator continence.
Yeah, incontinence.
If you're training, running, female athletes, runners, whatever, volleyball player, if they're having problems during their training with that, they're peeing, that would be the main indicator. Go ahead and get it checked.
Yes.
Right? And then anything else on that?
No.
Okay. Nope. And then, so one thing you said right there that can be confusing, and if I'm listening to you talk, maybe dive into this a little bit. You said the adductors are tight and they've got some tightness, but most people would look at females as being pretty hypermobile.
Yeah.
So is it more of a high threshold tightness?
Yeah, and typically, and here's the reset. You needle them a couple times. You give them some stretches. You go over form with, and single leg stance stability, shockingly bad on runners.
I'm glad you said that because there's a lot of trainers and coaches that can't go right to the incontinence issue, but we've had a long history working together of female athletes who on a leg raise, their hip clunks.
Yes.
On a prone press up, their back hurts. They have significantly reduced T-spine mobility, but it's because of high threshold and bracing. So one of the first things that I thought was a magic moment is when we were dry needling, we dry needle the adductors, T-spine mobility goes up.
Yes.
So when you have, and Lee spoke to that, female athletes are often more predisposed to being hypermobile.
Yeah.
And postpartum, you're going to be hypermobile because of the hormones that are available. But I was informally, I guess formally, your therapist going through your first pregnancy, and you just come in just all over the place, and we'd have to put an SI belt on you just to give you that level of stability. But I do want trainers and coaches to realize exactly what you said. When you screen poor balance, when you screen an asymmetrical leg raise, when you screen an asymmetrical lunge, when you have pain on prone press up, and when your athlete talks about clunking and popping and clicking, incontinence is probably right around the corner or also occurring. So there are a lot of other things we can discuss that would get us almost to that conversation, at which point a physical therapy exam would be warranted. And I honestly think that low back pain and pelvic floor function go hand in hand. And when I used to treat with a therapist that was at the clinic before you were, she was a pelvic floor therapist. And whenever I had a female athlete with low back pain that did comment to some other pelvic floor symptoms, we would address pelvic floor first. Half of what I needed to do to get the back ready was already done by the time I inherited that patient back and did some manual therapy on a hip or something like that. And so when you see an otherwise hypermobile person with unnecessary tightness, that's a prime mover being the only stabilizer you got. So stretching them out may not make them feel better. It make them feel worse because you're kicking the crutch out from under them.
Well, even in that situation, even doing quote unquote stability training may not be, because you think they're hypermobile and you're going to do this stability training because they got poor balance. So then you say, okay, let's do stability training, when actually they need to kind of reset, turn off the muscles that are on and then turn on the muscles that are off.
Right.
And I think that's what you're really alluding to, Cortney. And when I say high threshold strategy, what is that?
So it's like they create tone in a muscle to give themselves stability when they don't otherwise have it. And so, you know, for runners in particular, and I keep going back to runners because I just see so many of them, you know, they typically, their glute strength is terrible. They're running very long distances. And if I look at a dynamic single leg stance, they just collapse inward, you know, and I have found several exercises to be really not just the exercise, but also that feedback loop to them of when you can do this and you're not falling all over the place, you're good to go. Like you're going to know, you're going to get that, that feedback that, okay, things are firing that are supposed to be firing. My muscles are working that need to be working. I'm not going to be creating excessive tone in my adductors just to try to keep my legs stable on the ground. And so, yeah, I think for athletes in particular, female athletes, I did take one course that was pelvic health and the athlete just in general. And the guy that taught the class was the PT for professional hockey league. And so he talked a lot about just the mechanics, like hyperextension of the hip. And, you know, especially for hockey, you know, they've got that leg extended and abducted and straining those adductors all the time. And so that was a really good perspective of just male, female, it doesn't matter. Any of them can end up with pelvic health issues. Our pelvic health therapist does see both men and women. Oftentimes after prostate,
a male inguinal hernia is a pelvic floor problem, even though we don't put it under the umbrella. Many of the exercises, therapies, and screens that show you're coming out of that problem are in play. And a lot of people just don't look at it that way. They think unless you have a female's pelvic floor, you can't have a pelvic floor problem. But that high threshold, what we often see is the obliques come on before the TA, the pelvic floor, and the spinal stabilizers come on. So these people can plank impressively, but when you movement screen them, they don't look above average at all. So when you have somebody posting above average strength, but below average mobility and stability, you're looking at the train wreck getting ready to happen. So.
And what are some of the other transitioning from physical therapy back into training, specifically postpartum. What are some of the considerations on that side? Basically, if you got, because there's a lot of education on the fitness, performance, strength, conditioning world in that area, where you've got a lot of expertise or a lot of education experts in that area of training females after pregnancy. What are some of the things you need to, again, consider from your world that, again, may be, hey, this person probably needs to get into therapy. Training may not be getting them what they need.
Right. Typically, they'll complain of some sort of back pain or something if they're having issues. Diastasis recti, which is basically where the abdominals split and they don't come back together. I would say most women postpartum deal with that. So people think core, well, I'll just get back, I'll just do some crunches. Well, you need to train your abdominal strength differently when you have a tear in your abdomen like that. So, you brace the abdomen, and it's more Pilates style ab workout. So you're keeping your spine in a neutral position and engaging your abdominals differently. You can't just go back to planks. You can't go back to crunches and curl ups. That's really just going to make that problem worse.
And just to give people a visual image of what you just described, imagine looking at somebody's six pack. Well, that line right above the navel between the 2 3-packs, there's a little bubble that comes out under certain pressurization. And that's the linea alba. That's basically that 2 rows of abs sort of splitting a little bit. And more people have it than we think. And some people on a physical therapy exam, when we're just doing like, did you know you had a hernia? And I've said that to both men and women. And sometimes it's after pregnancy for women. Sometimes it's after something as simple as an abdominal surgery.
Yes. Yeah, so the diastasis recti is definitely a pretty common thing. We see them or our pelvic health PT sees them for positioning when feeding their baby. A lot of wrist, elbow, shoulder, neck problems from moms, trying to nurse babies. And so they educate them on proper posture. And even, once you have that baby, that center of gravity shifts. And so then you've got to really, if you want to be smart, you're going to go see a pelvic health PT because you're going to want to address your posture, just general postural control. So before returning to any kind of workout program postpartum, I think every woman should see a pelvic health PT to have an assessment. Do you have that tear in your abdomen? If so, this is the kind of ab workout you're going to do. Are you having pain in your pelvic floor, or are you having issues? Sometimes she just sees them for wrist issues, and it's just something related to how they're holding their baby. And it's like I said earlier, it's very much education. But before going to the gym and doing planks and what we would typically think of as like a good ab workout, they don't need to start there. That's for sure.
Because so many proactive females are actually anticipating pregnancy, and they get fit. They get fit before pregnancy, but the type of fitness sometimes they're reaching for isn't the type of fitness they need. And the simple fact of the matter is you shouldn't train and watch a movement screen get worse. That's the first indicator that you're starting to sacrifice quality for quantity. That's no way to go into pregnancy. But if you're already on the other side of the first pregnancy, the second one doesn't have to be that way.
Right.
So one other thing, you've been a patient.
Yeah.
And you're a walking miracle because we were pretty scared for you for a while.
Yeah.
But there are other women's issues that we deal with, and you can speak to that as well. That I think a lot of people don't realize how complex they can be. Shoulders, head, and neck type thing thrown off. So if you want to speak to that.
Yeah. So I had breast cancer in 2015. My kids were super young. When I got diagnosed, I was probably the healthiest I'd ever felt in my life. And so it was a real shock. By the time they got done taking what they were going to take and a year of chemo, and then, I was on hormone blockers for like 7 years after that. I resurfaced from that and thought I will never be the same again. I will never be able, I couldn't even make it up a flight of steps. And so I tell my patients a lot, I know what it feels like to work from the basement floor up. I have done it. And you just have to start with where you are.
Yep.
Is what I would tell anybody. I know you feel like you can't get out of your chair today. That is a problem. However, we can fix that. We're going to fix that. But if you say, well, I can't get out of my chair, so I'm going to give up, then that's where you're going to be. And so I do think it helps me to speak to patients in that regard. I know it's hard sometimes to push through things, but I have done it. In particular, right now, an interest to me is training in perimenopause and menopause, because I think that is very different. I follow Dr. Stacy Sims, and she's really smart with this topic. I love what she has to say. She says women are not small men. But however, they're trained that way.
You're right.
A personal trainer, most trainers are training women just like they would train a man. And I mean, I see it when I'm training in the evening. I see that. And the research is always changing on it. And it's like one person says fast and the other person says don't fast. And I think it is a very confusing now with social media. You're getting people's opinions and not so much the research behind that. But I do think Dr. Sims is very much into the research, into the forefront of research for women in this population. And that's where I am. I mean, I've been in menopause since I was 36 because of treatment. And so you immediately feel weak.
And
you have no power in your movement.
I honestly think you gave our trainers and coaches an insight. You said the 4x4 matrix, but what you're really meaning is a developmental progression.
Yes.
So the only way to do chops and lifts isn't half kneeling. We do a lot more mat work when we find these compromises, because it's really easy to substitute and compensate for your balance.
Mm-hmm.
But we watch people try to get up off the floor. And isn't it ironic that we've got, 30 years of people talking about fall prevention, but how about get up?
Yeah,
Meaning,
right.
If you fall, you got to get back up, because getting up off the floor in a very, very good way is one of the indicators that you're probably not going to fall. And yet, when you do have fall risk, so many people insist on training you upright like the machines want you to be, and they think functional is on your feet upright. Well, you got to get there through that developmental thing. So when we take the post-menopausal or the post-surgical patient all the way down to the mat, and we're doing stuff in quadruped, prone, supine, sideline, people don't understand that's badass training because of what it yields, not because of what it looks like.
Right.
Yeah.
Right.
And so,
well, I think one of the key takeaways, Courtney, what you said is meet them where they are.
Mm-hmm.
If you're struggling getting up from out of the chair, okay, start there.
Yeah.
If you know that they're going to be struggling on the ground, get them on the ground.
Right.
That's one of the biggest, questions I've gotten over the years. Well, Lee, I don't want to get my clients on the ground. I'm like, get them on the ground. I'm like, if they're scared to get on the ground, there's a reason they're scared to get on the ground, because they don't think they can get up.
Right.
Get a mat tables aren't that expensive.
Right.
Yeah. Get a mat table, get them to roll around, start them on the ground, meet them where they are. And I think that's a key takeaway. But I think, Courtney, the other thing, just maybe speak to a little bit more, is what are some of those differences? What are some of the other considerations? And if I'm a male training a female, give me some advice.
Well, Dr. Sims has said if you go into a gym and they hand you little pink weights, run. She is very much about lifting heavy. And I can testify to the fact that I feel much better lifting heavy. My workouts are not long. I'm getting in there and I'm doing power, functional movements, but heavy weight. And I'm just shocked. I will go to pick up a weight for a patient in the clinic and think, that felt really easy to me. This is great. I've even gone to a few CrossFit classes, and I love that. My first CrossFit class was an Olympic weightlifting class. Never done that in my life, and thought, I can see the benefit of working. And so now I'm doing some of those moves in my basement at home. But, lifting heavy is something she really promotes. And then eating. So she says, no fasting for women in menopause that are you get up in the morning, you should not train fasted. You need a little bit of protein, like 15 grams. And then after you work out, within 45 minutes, you need another 40 to 60 grams. Most women are not getting enough protein. They're very afraid. When I talk to women that I am doing performance type training with, they're trying to get back to something specific. And I say, well, let's try working towards lifting heavier. Well, I don't want to be bulky. I'm like, you're going to have to completely change everything in your life to bulk up like that. Like, you're not training for 2 hours a day. You're not going to get enough protein to bulk up. And so it's a hard sell, I will say, to women, because they're trying to do what men do. And that's just, men can fast and meal prep and cut back and do all that, and they're going to drop the weight, and it's totally different. And then women get frustrated because they say, well, I'm in menopause and all of a sudden I have this belly that I'm carrying around that I didn't have before. How do I get rid of it? Why did it happen? How do I get rid of it? And I can just tell you right now, most physicians don't care.
And
That's
when
not
we
a
get
concern.
back to holistic health, we do a little breathing screen. These same people that are getting that little belly and they're having a hard time with their metabolism, they're shallow breathing. There's a good argument that most of the time they're sleep deprived. If they do have some of the pelvic floor issues, we know they're dehydrated because they don't want to pee all the time, so they're not hydrating. And so it's a vicious cycle of dehydration, shallow breathing, poor sleep, but I got to work out. And that's a recipe for inflammation in many cases. And I've noticed this doing manual therapy or dry needling on female patients, and they come in a state of dehydration and they're sore for 4 days when they should only be sore for a day.
Right, yeah.
But it's because their metabolism is so freaking slow that they can't process. And so I say hydrate, and they're like, well, I'm going to pee all the time. And so it's this vicious cycle. And so, that stabilization therapy is going to help the incontinence. The hydration is going to help the breathing and the sleep. And you almost have to rebuild somebody, but you're dead on right. Not eating enough protein and showing up dehydrated and then expecting to work out. And your other point, long before you bulk up or add too much muscle, you're going to get bone density, better posture, and a better metabolism.
Right. And those are things that women in perimenopause and menopause, look, I fractured 2 ribs in August, following hormone blockers and cancer treatment. I had osteopenia. And when you're on a hormone blocker, they typically put you on something like Prolia, something for like a biphosphonate for bone health. Also, something really important, I think, for trainers to be aware of is, do their clients have osteoporosis or osteopenia? Are they on a bone health medication? Those are just basic screening questions I want to know for my patients. It's safe for them to lift heavy, but I was lifting heavy for 2 years when I came off the hormone blocker. They took me off the Prolia. Evidently, I was not supposed to come off that medicine. I was just doing a water sport, holding on to the rope. The boat was just beginning to accelerate, snapped 2 ribs. And so then at that point, I thought, okay, I have osteoporosis. I gave myself the 6 weeks off, and then I said, I will lift heavier. And so that is what I'm doing. I'm back on, I had to get back on Prolia. Evidently, you just don't come off that medicine once you're on it. But I think from a training perspective, it's important to know those things. Wolff's Law, the bone is going to respond to the demands you place on it. So the heavier these women lift safely, working up to that, obviously, the better. And I have some older clients that see me kind of continuity, check in with me. This is what I'm doing. And they're getting heavier and heavier. And they're talking about, I went to pick my real estate sign up out of the ground, and I just picked it up and marched on and felt great. She said, I used to hardly be able to get it out of the ground, much less carry it to my car. She's a very petite female. And so the training does need to be different. I haven't done a deep dive into specifics of how many. I think she says like 3 or 4 days a week needs to be weight training for women, not so much cardio. She talks about interval training. So as hard as you can for 30 seconds, rest for a minute. So I've definitely worked in some things like that. It makes a difference. I feel totally different in menopause that way.
I've also found on a non-gym day that just something as simple as the weighted vest or rucking, meaning you're walking, so it's not really high impact, but having that postural load, that little bit of top heaviness, and you can always pick the weight. But it really does get the posture where it's supposed to be because, as you said, you mentioned Wolf's Law, which is basically just load a bone, it gets stronger.
Mm-hmm.
But if you load the bone not in a vertical way, it gets weaker or stronger only in one direction. So I found that on a non-gym day, simply getting your steps in with a little bit of upper body weight really does help you foster the lifting heavy the next day. So that's a positive benefit. And a lot of people, it's a good on-ramp to start because I think in a podcast we had last year with James Breeze, he talked about the people who actually achieve their fitness goals and the ones that don't, even though everything else is the same, 7 hours of sleep, 7 cups of water, 7,000 steps. If one of those isn't where you are right now, it's almost more important to get there, and then you'll see your program go because that's just the flush that your body needs to actually go through a training cycle and a proper recovery. You're simply not vertical enough, hydrated enough, or rested enough to benefit even from the good exercise.
Right.
So that's that homeostatic base that I think we all forget.
So yeah, the weight loss shots, I have a lot of patients on those. And what's happening is what, I hope this doesn't sound bad, but it just makes them skinny fat. So it's like just eating their muscle and then they just are carrying around their skin and their fat, like
and it's no behavior
not
modification. It's just do the same thing you've always done, but have this appetite blocker that really is doing harm.
Well, but I think that's where the problem comes in, is when it's prescribed, it's always prescribed with, you got to change your behaviors.
Yes,
It's always prescribed to say,
so it's blood pressure medication and never come off of
blood
it.
pressure medication, all these medications are always, the little asterisk says, well, you've got to eat right, you got to exercise, but because this thing works so well,
you don't. It would be better if you did.
What they tell me is they lose their desire for much of anything. So they don't want to eat, they don't want to hydrate. I had one patient that basically was going into kidney failure. She would go all day and drink not a drop of anything. Some of them are nauseous, so they, just even the mere thought of eating is a turnoff to them. So then obviously not getting enough protein. So I've encouraged them, I don't care if you get it in a Premier shake or maybe not ideal, but something, get some protein in your body, and then you need to do some basic strength training. It's just they don't have the energy for that. And that's where I have real concern.
And I think from my limited knowledge, and I'll just use this in my terms, I don't think they've got the witch's brew quite right yet.
Right.
Because, like you said, the side effects, which are part of what they want.
Yeah.
Feeling nauseous, not wanting to drink, not wanting to do that, not quite right just yet. And I don't believe, again, my opinion, the people that really, really need it, it's appropriate.
Yes.
But then you get these borderline people that, you know what, if you just changed your diet and exercised, you would probably get there in a better way versus speeding this thing up.
Right.
And I think that's where we're not quite there yet on both the actual drug, the witch's brew, but also just the advice. Because it's way too easy. Because I was speaking to someone about a year ago, said you couldn't find any in New York City because all the upper echelon individuals were taking it because they wanted to lose 10 pounds.
Yeah.
And it's just not the right recipe right now.
Mm-mm.
For some people, the type 2 diabetics, the way obese individuals who we've got to do something for that segment of the population. But that segment of the population needs it so they don't have a heart attack or die and have a stroke.
Well,
Right.
now Medicare won't let you have a total knee replacement if your BMI isn't at a certain level. So our doctors are having to say, not yet on that total knee, because, insurance is saying your BMI has to be, I don't know, below 30.
And that brings a great point up. I need a total knee, so I can't exercise. And I got to lose weight to get my total knee, but I still can't exercise. So what do? Just ride a bike or take the shot or whatever. And that's where, once again, we go right back. You give me a half hour on the mat, non-weight bearing, I can actually get you ready for knee surgery, and we can create enough of a metabolic demand to start losing some weight right there with a little bit of dietary advice and some sleep. But when people are taking a shot to lose weight so they can get the total joint, they're getting ready to go into that total joint replacement with reduced bone density.
Oh, yes,
and I got to
and
plant
weak.
that implant in a bony matrix that shouldn't be soft, and yet you're going to be light. So I think sometimes, since we all know that obesity, overweight, morbid obesity is a risk factor, we forget that while we're attacking that single isolated risk factor, we create three more in malnutrition, muscle loss, bone density loss, metabolic suppression.
Mm-hmm.
It's not a good cocktail right now.
I have a patient that's on his maintenance dose right now and feeling very weak. Lost, I think, 75 pounds. And he needed to lose that weight for sure. I don't really know that there have been tremendous dietary changes despite us having that discussion. But now he's saying, I need a shoulder replacement. I need a knee replacement. I feel so just weak as a kitten. I need help just to get to where, now that I've lost this weight, I can go have that joint replacement. And so that's what we're working on, just general strength training. And he has horrible arthritis. I mean, you can just feel the joint just clicking every time he moves it. So it's really bad. But I'm doing all I can to help him because I want him to have that joint replacement. But I do have some concerns post-operatively with healing and everything, because you got to be getting that protein, and he doesn't have the desire to eat.
No, I've got a few people that train the Hollywood elite, and they said when they're taking the shot, they claim I can get through the day on 2 Diet Cokes and a bag of chips. And I'm like, that's not good. I mean, I know they're dropping weight, but they're craving salt because they're dehydrated. So they're going to get that through chips, and they're craving some degree of sugar to keep their brain alive. Diet Coke ain't giving you that. And so, but yet they claim, I can get through a whole day on 2 Diet Cokes and a bag of chips. And I'm like, that doesn't end well. So.
Yeah. The fallout of that, I think we'll be seeing that for a while.
But the bottom line is, I think we can meet every one of these issues exactly where you said, whether it's a female issue or a young athlete, somebody after post-mastectomy, or somebody trying to do aggressive weight loss, simply by screening them the first and finding out what movements they can handle and not handle, and using the reduced postural load instead of just going to pink dumbbells and lightweight. We can do heavy stuff or demanding stuff, simply getting up and down off the floor and doing those developmental patterns. And yet it helps the low back patients, the pelvic floor patients, the patients that have lost shoulder mobility, the ones trying to lose weight. And we're not using exercise machines. We're using gravity in you. And I think a lot of people forget about those functional options, but you can't set those goals and baselines unless you screen first. And that's where the blind spot gets not blind anymore.
Yeah, that's definitely, I do want to say I really appreciate personal trainers. I think people that are training individuals that need that motivation, I hear them out there, you've got this, you can do this. And there are people that really, really need that kind of motivation to show up. So I commend personal trainers. I definitely think if they would really step up their game, if they were screening people and doing what I said, what you mentioned, just meeting them where they are. If they have pain, get them in with a PT you trust. Let that PT address that issue, that pain that they're having. It does not mean they have to stop training. It is very rare for me to tell someone stop. You know, I'm usually like, no, you can keep going. You're going to keep going, but this is what you're going to do to modify that activity. And so it is definitely possible to get and to circle all the way back to what you said to begin with, to have that trust between professionals, chiropractors, PTs, trainers. It needs to be there. The only person suffering from that disconnect is the person we're all saying we're trying to help, which is the crazy part of it. So, and I believe that most of us are in this because we like helping those people. So, you know, that's what I'm doing with my side business, is really trying to develop those relationships with other professionals, get my little network of, you know, if you need to see a doctor, this is the one I recommend. This is an excellent trainer. This is a great chiropractor. I want to have a team, a healthcare team that I'm part of in my own little community there, that I feel safe giving referrals out to.
What people don't understand is even us three in the room aren't always functional, not always healthy.
Right.
But we treat each other. We listen to each other's advice. It's very hard to treat yourself. And if you're listening to this right now, hopefully, and I can't guarantee this, but hopefully somewhere on our website, you can find a chiropractor or a PT or an athletic trainer that can take you through an SFMA. So if you're the one coaching and training and you got issues and you don't have time to work on that, be the change that you want to make in your clients and go ahead. And believe it or not, you might not always find the best clinician right off, but if you keep on it, you're going to find somebody who's delivering exactly what we're talking about. Right. And if they can help you, they can probably create a network relationship and help your clients too, so they'll continue to be your clients. Right. So, yep. All right.
Anything else?
No.
Okay. All right, Andy, should we just do a quick wrap? All right. Yeah, I think that may be the best way to kind of wrap this up is try to create that network of individuals. Nobody is an expert in everything,
right? But
create the area that you think you need some more guidance in. Reach out to someone in your community, no matter where you are. You've got physical therapists, athletic trainers, as you said, Gray. You got the fitness and strength conditioning. So we all could benefit by creating that network. So Cortney, I really enjoyed this episode, and thank you so much for coming in and joining us.
Well, thank you for having me. I appreciate coming.
Thank you.
Mm-hmm.
If you want to learn more about today's podcast or dive deeper into functional movement systems information, check out some of the resources and offers we're providing in the description. That will do it for this episode of the Movement Podcast.
Thanks for listening. And if you liked what you heard, please take a minute and subscribe and review.
If you want to learn more about our system and take the next step in your own movement journey,
visit us at movementpod.com.
Until next time, be sure to first move well,
then move often.